Good evening, everyone. On behalf of the Education and Professional Development Committee and DEI Committee, I would like to welcome you to all today's webinar entitled The Pharmacist's Role in Addressing Systemic Racism in Healthcare by Dr. Lynn and Health Disparities in Estimation of GFR and CKD, an update for pharmacists by Dr. Katie Cardone. To introduce our first speaker, Dr. Lynn is an assistant professor of pharmacy practice at Wilkes University Nesbitt School of Pharmacy. She joined the Department of Pharmacy Practice after completing pharmacy practice residency training in the ambulatory care setting at Carolina's Healthcare System Northeast in Concord, North Carolina. Her clinical practice site is at the Wright Center for Primary Care Mid-Valley in German, Pennsylvania, where she practices as an ambulatory care pharmacist. Her professional and educational interests include diabetes management, in which she is board certified, anticoagulation, heart failure, hypertension, and COPD and asthma. Dr. Lewis's most current research and scholarship initiatives are focused on integrating diversity, equity, and inclusion into the pharmacy curricula. She has presented statewide and nationally on these topics. She's on the University Council on Diversity, Inclusion, and Equity and has helped to form the first Diversity, Equity, Inclusion, and Accessibility Task Force at her School of Pharmacy. And to introduce our next speaker, Dr. Katie Cardone. She's an associate professor and pharmacy program director at Albany College of Pharmacy and Health Sciences in Albany, New York. Dr. Cardone maintains a clinical practice and research program focused on improving care in patients with kidney disease and outpatient nephrology and dialysis. She recently co-led the publication of pharmacy practice standards for pharmacists caring for people with kidney disease. Dr. Cardone currently serves as a residency program director for the college's ASHP accredited PGY2 ambulatory care residency. She's a member of the Board of Pharmacy Specialties Ambulatory Care Pharmacy Council and is a fellow of the National Kidney Foundation, the American Society of Nephrology, and the American College of Clinical Pharmacy. Before we get started, I'd like to share a few quick points. For those who have any technological issues during the presentation, please use the chat option in the bottom right-hand corner to communicate with the office, and every effort will be made to assist in resolution. For those who have questions that you would like to direct to the speaker, please use the question box or chat option at the bottom of the screen. And the CE codes for this program will be provided at the end of each presentation. So thank you everyone for joining tonight, and I will pass it off to Dr. Lynn.
Thank you much, Shanice, for that introduction. Thank you all for having me here today on a Thursday. We have a Friday Eve, so I appreciate you all taking your time. I cannot be more grateful to have the opportunity to talk about this topic, and I'm grateful for all of you on the other end of the computer taking time out of your day to have such meaningful conversations. I appreciate your open mind to dive into a sensitive but overall necessary conversation. And overall, I wanted to thank the New York State Council of Health System Pharmacists for organizing this DEI webinar series to make this possible. So the title of my presentation is The Pharmacist's Role in Addressing Systemic Racism. In terms of disclosures, I have nothing to disclose in terms of any significant financial relationships with any commercial entities. So let's jump into this conversation by starting off with an activity to kind of get our feet wet a little bit. So what's going to happen is on the next slide, I'm going to show you a picture of an animal. So I ask that in the Zoom chat, you type the name of the animal that you see initially. So your first reaction, what is the first animal that you see? Okay, makes sense, pretty straightforward. All right, awesome. So I'm gonna go to the next slide and make sure that you type in the chat the first animal that you see. Are you ready? So I'll give it about 10 to 15 seconds and we'll see what everyone has in there. So which animal did you see first? So awesome. So was it a frog? Was it a horse? Obviously there's no correct answer. So some people said they saw one first and then they saw the other secondly. So let me see. So here is our outline of our frog. Here's our frog's eyes, our frog's mouth, the front leg, the hind legs. The frog is on a body of water, and that's the blue water right here. Or maybe you saw the horse. So this is the horse's head, the horse's nostril, the mouth, the eye, the ear, and then this would be the horse's mane. Maybe if I tilted it this way, initially you may see the horse based on the fact that I rotated the screen a little bit. Perhaps if you live near a pond, you saw the frog first. And if you live near a farm, you immediately recognize the horse. What's interesting is that once you are aware that there are two different ways of seeing the same thing, you're able to appreciate both perspectives equally. Everyone has a different lens, a different perspective, and different lived experiences. So hopefully after getting involved in this discussion today, your whole lens and perspectives are broadened to consider additional things you may not have thought of before, or to expand on some concepts and ideas that you have already had much thought about. But regardless, my whole point is that I hope that you're able to appreciate a perspective considering the effects that systemic racism on health outcomes and where you as a pharmacist can play a role. All right, wonderful. So let's dive into our learning objectives. By the end of this presentation, you should be able to, 1, define social determinants of health, systemic racism, health equity, and health disparities. 2, review the impact of racial health disparities on patient health outcomes. And 3, discuss considerations for action for pharmacists to address the issues of systemic racism and associated social determinants of health. So overall, we're going to brush up on some definitions, have a general discussion with the problem at hand, and then dive into some concrete examples and things that we may be able to adopt. So before we dive into the content, let's take a pre-test. Let's assess our baseline knowledge. I'm going to review these questions now, but we will not review the answers collectively as a group. So I ask that you answer them to yourself and reflect on what you think the correct answer is. Throughout the course of this presentation, we'll discuss some of these concepts, and hopefully by the end of the presentation, you should be able to answer them successfully. All right, so let's see. Question number 1 is a multiple choice that states, race is defined as which of the following? A, a social construct, B, a biological construct, C, a genetic construct, or D, all of the above. Race is defined as which of the following? So remember, we're not going to reveal the answers quite yet, but we will come back to these questions at the end. Okay, question number 2. The conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks is the definition of which of the following? Is it A, social determinants of health, B, systemic racism, C, racial equity, or D, cultural competence? The conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. All right, moving on to question number 3. True or false? The upstream concept proposes a shift in addressing health disparities by identifying the root causes of concerns geared towards targeted macro-level interventions. So true or false? We're speaking about the upstream concept. And then moving on to our last pre-test or baseline assessment knowledge question is an open-ended question for some self-reflection. So at the beginning of this presentation, current with the knowledge you have now, what are some effective strategies pharmacists can implement to best address health disparities? All right. So let's start off by diving into background information. Let's take a look at some definitions and historical context. So the first definition I have here is race. So the definition of race is a made-up / artificial social construct that categorizes people based on visual differences. So race is social, it's not biological, it is not genetic. Race is based on appearance, but sometimes it is assumed to be based on deeper biological connections. And we'll discuss later on what some of the consequences are when we attach biological connections to race categories. Race categories are amorphous or they're fluid. They change with time. These categories change based on social, economic, and political needs of a society at that time, which reflects truly that they are social rather than physical concepts. Race is shaped by things like geography, cultural affiliation, and social factors. To show that race is based on social and societal factors in a given time, I've included information from the Pew Research Center. So they have created an interactive virtual historic timeline from the US Census Bureau race categories from the first census in 1790. And that's what I have here on your screen. They do that from 1790 all the way up to current age. Because race is a social construct, the category names often change in reflection of current policies, science, and public attitudes at that time. So for example, from the first census you're seeing there, we start off with just categories of white versus slaves versus other free people. If I click through 1850 consensus, you see that we're adding some more categories here. 1860. So I've only included a few examples here, but you can see that the names and the categories are growing, the names are changing. For example, we see Black, we see Negro. The term Negro was actually dropped from the 2020 census, and African American was added later in. Here's 1890. We're expanding on more categories. And then I jumped to 2020 here to show you an example. Here's a picture of the full timeline that the Pew Research Society really has from 1790 to current day. So really showing us how this changes over time, once again, based on the social, economic, and political needs of a society at that time. So now that we've defined race, that'll bring us to the definition of racism. Racism is race prejudice plus social and institutional power. So any policy, belief, attitude, action, or inaction which subordinates individuals or groups with little social power based on their race. So then finally, it'll tie us into our big buzzword for the day, systemic racism. So what is systemic racism? So systemic racism can sometimes be referred to as structural racism or institutional racism. So we're going to watch a quick video on systemic racism. This video gives a quick but a thorough overview of systemic racism. It uses two examples of two boys, and these boys have completely different lives based on systemic injustices that have been woven into society for many years that they experience. I will say the video is slightly corny, but it displays a good visual through animation to drive home the basis of this definition. Now, the end of this video, it's about 4-ish minutes long. The end of this video talks about some solutions for the general population. But at the end of our presentation and our discussion today, we will talk about what we can do as pharmacists specifically. So I'm going to hit play.
This is Jamal. Jamal is a boy who lives in a poor neighborhood. He has a friend named Kevin who lives in a wealthy neighborhood. All of Jamal's neighbors are African American, and all of Kevin's neighbors are white. Because Jamal's school district is mostly funded by property taxes, his school is not very well funded. His classrooms are overcrowded, his teachers are underpaid, and he doesn't have access to high-quality tutors or extracurricular activities. Kevin's school district is also funded by property taxes, so his school is very well funded. His classrooms are never crowded, his teachers are very well paid, and he has access to high-quality tutors and lots of extracurricular activities. Kevin and Jamal live only a few streets away from each other. So how come they're growing up in such different worlds with such different opportunities for success? The answer has to do with America's history of systemic racism. To understand it better, let's look at what life was like for Kevin and Jamal's grandparents. Decades after the Civil War, many government agencies started to draw maps dividing cities into sections that were either desirable or undesirable for investment. This practice was called redlining, and it usually blocked off entire Black neighborhoods from access to private and public investment. Banks and insurance companies used these maps for decades to deny Black people loans and other services based purely on race. Historically speaking, owning a home and getting a college education is the easiest way for an American family to build wealth. But when Jamal's grandparents wanted to buy a house, the banks refused because they lived in a neighborhood that was redlined. So Jamal's grandparents were not able to buy a home, and because colleges could prevent them from attending through legal segregation, their options for higher education were really scarce. Kevin's grandparents, on the other hand, got a low-interest loan to buy their first house and got accepted into a handful of top universities, which traditionally only accepted white students. This opened up a wealth of opportunities that they were able to pass on to their kids and grandkids. Even as late as the 1980s, an investigation into the Atlanta real estate market showed that banks were more willing to lend to low-income white families than to middle or upper-income African-American families. As a result, today, for every $100 of wealth held by a white family, Black families have $5.04. A 2017 study confirms that redlining is still affecting home values in major cities like Chicago today. This explains how Kevin and Jamal inherited vastly different circumstances. Unfortunately, the story doesn't end there. A big part of systemic racism is implicit bias. These are prejudices in society that people are not aware that they have. Let's go back to Kevin and Jamal. Against all odds, Jamal manages to be the only student from his high school to get accepted into a great university, the same one that Kevin and his high school friends are attending. But after Kevin and Jamal both graduate, Jamal notices that his resume isn't drawing as much interest as Kevin's, even though they graduated from the same program with the exact same GPA. Unfortunately for Jamal, studies show that resumes with white-sounding names get twice as many callbacks as identical resumes with Black-sounding names. Implicit bias is one of the reasons why the Black unemployment rate is twice the rate of white unemployment, even among college graduates today. You can see evidence of systemic racism in every area of life. The disparities in family wealth, incarceration rates, political representation, and education are all examples of systemic racism. Unfortunately, the biggest challenge with systemic racism is that there's no single person or entity responsible for it, which makes it very hard to solve. So what can you do? The first thing you can do is work towards becoming more aware of your own implicit biases. What are some prejudices that you might hold that you're not aware of? Second, let's acknowledge that the consequences of slavery and Jim Crow laws are still affecting access to opportunity today. As a result, we should support systemic changes that create more equal opportunities for everyone. Increasing public school funding and making it independent from property taxes would be a great start so that poor and wealthy districts can receive equal access to resources. Systemic problems require systemic solutions. Luckily, we're all part of the system, which means that we all have a role to play in making it better. Peace.
So as I mentioned, yes, the video is a little corny, but it's a quick way to kind of define systemic racism and see some of its effects. So overall, the official definition I have here is the combination of laws, policies, and rules that are embedded within society and organizations that generate and reinforce inequities disadvantaging groups of color. So although redlining is now illegal, like we saw in the video, it is clear to see how the systemic effects of segregation and racism have lasting downstream effects on society today. This can be a great segue to discuss social determinants of health. So as defined by Healthy People 2030, social determinants of health are the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. So the social determinants of health we have listed here are economic stability, neighborhood and physical environment, education, food, community and social context, and healthcare system. Systemic racism is a key, but often an underemphasized concept under this entire social determinant of health umbrella. In the United States, each of these domains are deeply rooted in systemic racism. It's racism, not race, that can be the primary driver of those social determinants of health. It drives the inequities in housing, income, and education, especially among our communities of color. In many ways, systemic racism isn't one of the social determinants of health, but it's the underlying structural determinant that sets the stage for all of the other social determinants of health. For example, people who do not have access to grocery stores with healthy foods are less likely to have good nutrition. That raises their risk of health conditions like obesity, heart disease, diabetes, and even lowers life expectancy relative to people who do have access to healthy foods. Racism plays a fundamental role in someone's social determinants of health, and that is what we're going to discuss in the next sections of this presentation. So in the next section, we're going to kind of tie all of these definitions together to see the impact on health outcomes. So now shifting gears to discuss health outcomes, we're going to look at systemic racism's impact on patients' overall well-being. Data shows that racial and ethnic minority groups throughout the United States experience higher rates of illness and death across a wide range of health conditions when compared to their white counterparts. Additionally, the life expectancy of non-Hispanic Black Americans is 4 years lower than that of white Americans. And something that we're all familiar with, the COVID-19 pandemic and its disproportionate impact among racial and ethnic minority populations, is just another strong example of these enduring health disparities. But if we want to build a healthier nation, we must confront the system's policies that have resulted in generational injustice and that has given rise to racial and ethnic health disparities. So let's dive into that right now. As mentioned, systemic racism can lead to negative health outcomes known as health disparities. Racial health disparities are defined as health differences that are closely linked with social, economic, and/or environmental disadvantage that adversely affect groups of people who have systematically experienced greater obstacles to health based on their race. And please note that health disparities can be based on other things, such as religion, socioeconomic status, gender, age, sexual orientation, gender identity, so on and so forth. But for purposes of this presentation, specifically talking about racial health disparities. We want to decrease our racial health disparities, and we want to increase health equity, which is defined as valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities, aka the attainment of the highest level of health for all people. So let's bring it all together. So this graphic is from a Berkeley publication titled Towards the Abolition of Biological Race and Medicine. I love this graphic. So this graphic was created by Dr. Joya Creer-Prairie. So let's start on the left of this graphic. So Dr. Creer-Prairie shows that health disparities start with root causes: racism, class oppression, gender discrimination, and exploitation to create deep power and wealth imbalances across much of the systems that govern our lives, such as globalization and deregulation, labor markets, housing policies, education systems, so on and so forth. In turn, these things mold the social determinants of health by shaping who is paid how much and with what benefits or what job security, who lives where, what quality of housing can they afford, what quality of education exists for them or for their children, what quality of food is available, and much more. Differential power distributes these social determinants differently depending on who holds and who doesn't hold power. And this tends to fall primarily along race, class, and gender lines who hold multiple marginalized identities, such as Black working class women. And this is a concept also known as intersectionality, which is termed by Dr. Kimberly Crenshaw. But a discussion on intersectionality can take an hour in its own, so we won't get there. But overall, you understand the point that I'm making here. These social determinants of health lead both to unequal distribution of disease and well-being. So for example, increased asthma rates in neighborhoods with poor quality housing and increased environmental exposure, as well as, psychosocial stressors and unhealthy behaviors. If we take a step back and we look at this graphic, we see a vicious cycle. One thing is leading into another, and it's starting with racism. I am a full-time assistant professor at Wilkes University, go Colonels, and I have a key role in educating our future pharmacists. So now let's take a look at this right side of this graphic here. Looking at the right side, when clinical education and medicine conflate the social construct of race with biology, it entrenches racism across the system. This means we as providers not only fail to address and practice how racism is creating health disparities, we also create and further feed into racial health disparities. So for example, if I teach my APPE students that Black children have a higher prevalence of asthma in the US, and I just start there, they may be thinking that it's due to DNA, not because of the living conditions of many Black children in the United States, predisposing them to harsh environments and conditions that increase asthma. I'm only teaching them half of the story, leading students to assume a biological correlation. This and several other examples outlined in literature, such as the calculations for kidney function, which I know that we'll be talking about in the second presentation for today, show how physicians conflate racial health disparities with biological difference. This can affect how we treat patients of color, further causing a differential distribution of certain diseases by race. And furthermore, it fundamentally distracts us from the true ills that negatively impact patients' health outcomes and their well-being, with racism being the root cause for these inequities in our society. This inattention to the root cause and direct creation of health inequities is truly our call to action as healthcare providers and as pharmacists. So through the next section of this presentation, I hope as pharmacists, We can join in on the vision of a world where the social construct of race is not conflated with biology, and where the health consequences of racism are acknowledged, they're addressed, and they're cared for on all different areas. So overall, with that being said, what is our goal? Our goal is racial justice. So I wanted to use another group of graphics that are my favorite to bring this together. These graphics involve two boys and an apple tree, and you may be familiar with this one. So here's a first picture of inequality. So unequal access to opportunities. So we have unequal access here in this picture. We have these two boys, they're looking to pick apples at this tree, and we have unequal access to the apples because the tree is tilted to the left, giving the boy on the left the opportunity to get an apple in his direction based on his location. So what about equality? So evenly distributing tools and assistance. So each boy in this example receives the same size ladder, equal support, equal aid. However, there is not equal opportunity to begin with since the tree is tilted to the left, once again giving the boy on the left the opportunity to pick an apple. So what about equity? Is equity what we want? So equity is where we customize those tools to identify and address the inequality. Here, the boy on the right now has a slightly higher ladder. This adjustment allows him to have the same opportunity to pick an apple as the boy on the left on his lower ladder. However, we could take this one step further and we can aim for racial justice. So justice is where we correct the system from the beginning to offer equal access to both tools and opportunities. We are fixing the root cause. So here on the screen, I have written the systematic fair treatment of people of all races resulting in equitable opportunities and outcomes for all. The presence of deliberate systems and supports to achieve and sustain racial equity throughout proactive and preventative measures. So here in this graphic, we are fixing the root cause of our apple picking, AKA the left tilt in the tree, which was what started this. We added in some pulleys, we used some wood, we straightened out our tree. We're being proactive and we're putting in place preventative measures that help the next group of boys who want to pick apples. So moving into our last section, we're going to talk about the pharmacist role. Unfortunately, the biggest challenge with systemic racism is that there is no single person or entity responsible for it. That is what makes solutions so difficult. Systemic changes are needed to get to our goal of racial justice and equity for all. Systemic problems require systemic solutions, right? And we are all part of the system and we can all have a role at making it better. But where can we start? So let's look at some considerations for action for pharmacists to address health disparities rooted from the issues of systemic racism. The way I'm going to kind of progress through this section is I'm going to discuss possible interventions and actionable considerations through the social ecological model. So the social ecological model recognizes individuals as embedded within larger social systems. So it describes the interactive characteristics of individuals and environments that underlie health outcomes. This model is used in public health to influence health outcomes and affect behavior change. Intervention strategies can be implemented at each level of influence, and we're going to talk about all of those levels and kind of correlate it to the actions that we can take as pharmacists. So here is a picture, a makeshift picture that I made of the 5 levels of the social ecological model. So we have intrapersonal at the beginning, interpersonal, institutional / organizational level next. Then we branch out further to the community level and then branch out again to public policy and system level. We're going to dive into each level and discuss interventions that can be employed by pharmacists in attempts to address health disparities rooted from issues of systemic racism. So first, let's start off with intrapersonal, the interpersonal level. So the interpersonal level are patient-level interventions. So this is education, training, skills enhancements of our targeted population or individual, AKA our patients. So what can we do to assist our patients? So I have some examples listed here on the screen. Things such as culturally sensitive patient education, One of our primary responsibilities as a pharmacist is to educate patients. Pharmacists can provide counseling on prescription and self-care medications, and pharmacists in the hospital and clinical setting can ensure patients understand their medications at discharge and transitions of care. In any setting, we can advise patients on the management of chronic diseases. But most importantly, I have culturally sensitive patient education. So importantly, pharmacists must be able to communicate with patients from diverse cultures, diverse backgrounds, and beliefs, and even work with an interpreter as needed for language barriers. Another thing we can help out with is medication affordability. As we know, high-cost medications pose a significant burden to adequate health care. There are so many ways that pharmacists can help reduce medication costs. We can recommend cost-effective therapeutic alternatives, help with discount cards, copay assistant cards, manufacturer patient assistant programs. We can help patients even apply for insurance, such as identifying an appropriate Medicare Part D plan. We can help patients identify federally funded programs or local charitable clinic pharmacies as well. We can help with medication adherence interventions. So we know that medication non-adherence can lead to increased healthcare costs, progression of disease, and an increased rate of avoidable hospitalizations. So we can offer many practical approaches, such as the recommendation of combination pills to reduce pill burden, automatic prescription refills, pill boxes, medication reminders, custom pill packing. We could do blister packs, request 90-day supply. We could do med sync services where we're scheduling the fill of multiple medications at once. We can also utilize pharmacy claims data to identify patients who are at risk for non-adherence and make personalized interventions. I also have listed here things such as primary prevention strategies and screenings. The list goes on. We can provide immunizations, perform health screenings and point of care tests, conduct disease state management education classes like DPP classes, offer smoking cessation counseling, perform health screenings, naloxone training, opioid harm reduction. We can even distribute contraceptions, telehealth services, or any other innovative means to help our underserved patients. Through these primary preventive strategies, social needs, screening and referrals, and interdisciplinary collaboration, pharmacists can expand access and quality of care to our patients. Other things I have listed are improved participation and research in clinical trials and the appropriate use of precision medicine. So precision medicine, sometimes known as personalized medicine, is an innovative approach to tailoring disease prevention and treatment that takes into account differences in people's genes, environments, and lifestyles. So this is not to be confused with making a medication recommendation based on the color of somebody's skin, but rather by personalizing it precisely based on their genome. Next, let's move on and discuss interventions at the interpersonal level. So we just talked about intrapersonal. Now we're going to move on to interpersonal level. So this is the education, the training, skills enhancement of people who interact with our patients, who interact with the target population. So this can be us, pharmacists, healthcare workers, family members, friends, teachers, and coworkers. So I broke up this slide into two different areas. So I broke this up into actions for self. So what can we do for ourselves to enhance our interactions with our patients? And then the other side is actions to others. So what can we do to or with others to enhance other people's interactions with patients? So first, let's talk about actions for ourselves. So we can increase our self-awareness of implicit biases. So that was alluded to in the video, and I'll talk a little bit more about that, and trainings. So when I say things such as trainings, an example would be this CE. Everyone being here on this webinar, this mini series, we're learning and we're expanding our knowledge. Demonstrating cultural competence can improve the quality of healthcare through enhanced communication with our patients, and that develops trust and it facilitates the closure of sensitive information. Taking individual responsibility to deepen our own awareness around systemic racism and its impact on our patients and communities is imperative. You and only you are responsible for your own education, your own growth, and your own development. So I'll come back to the side, but let me go forward and let's talk about these biases. So what do I mean when I say implicit biases? And this is a buzzword, we've heard it in the video. So it's contrasting to explicit biases. So conscious and intentional biases, individuals are aware of prejudices and attitudes and they're expressed directly, where implicit biases are unconscious or hidden biases expressed indirectly. So this is the subconscious attitudes or stereotypes that affect our understanding, they affect our actions, our decisions in an unconscious manner. They're activated involuntarily and without an individual's awareness or intentional control. Our implicit biases cannot be accessed without true introspection, and we all have implicit biases. Unconscious opinions and prejudices are a normal part of human cognition. The one thing I think that is crazy to think about is that our implicit biases can run contrary to our conscious beliefs. So let me say that again. Our implicit biases can run contrary to our conscious beliefs. So for example, I can consciously say that I practice by treating all of my patients fairly, but subconsciously, I could recommend less pain medications for males than females because I have this unconscious belief that men are tougher than women. And both of those things could be true. Consciously, I'm deeply committed to providing the best care for my patients, but unconsciously, I may be doing harm. And that's why implicit biases can be so complex. They can be so dangerous, and it's hard to adjust without deliberate introspection and self-reflection. Here on this slide, I have some examples of what we can do to increase our awareness of our implicit biases. On the screen, this is the implicit framework, and this is recommended by the American Academy of Family Physicians. However, this can be employed by any healthcare provider, not just a physician, and even non-healthcare providers. This is an acronym that goes through the 8 letters of the word implicit, and it has some action and potential resources to work through those implicit biases. So they have things listed such as introspection, to explore and identify your own implicit biases by taking implicit association tests or through other means. Know your triggers, plan ahead. The biggest thing is that awareness is the first step. M, mindfulness. Practice ways to reduce stress and increase mindfulness such as meditation, yoga, and focused breathing. P, perspective taking. Consider experiences from the point of view of the person being stereotyped. This can involve consuming media about those experiences, such as books or videos, and directly interacting with people from that group. So seek to understand, ask open-ended questions to your patients, express empathy and show humility, have an open mind. L, learn to slow down. Pause and reflect on your potential biases before interacting with people of certain groups to reduce reflexive reactions. So pause before responding, think it through. Remember that the unconscious mind is really fast. It's faster than you are consciously aware, which is what makes this tricky. So allow yourself time to make deliberate decisions. I, individuation. Evaluate patients based on their personal characteristics rather than those affiliated with their group. This can include connecting over shared interests or background. So I just gave an example of this with my students last year, the group of students I had on site with me. So I have patients who come in and we train them on continuous glucose monitors. And I had a patient who we had a sample of a continuous glucose monitor. So I set up the box for the patient, and what happens is me and my students go into the room and we make sure that the patient is comfortable, competent, and confident on how to utilize that device. And a continuous glucose monitor will come with a sensor, a transmitter, and a reader. So making sure my patient understands all those different areas. So we literally spend about 45 minutes with a patient going through all of the different steps to make sure that they are comfortable. Now, the patient that I was educating was about 80 years old. So I go through all of the steps with this patient, making sure that she understands, how to utilize this after she leaves the clinic, and she's going to independently utilize this. And I ask, do you have any questions before we set you off? And she goes into her purse and she pulls out her iPhone 13. She's like, Troy, I'm just confused. You just went through how to use this really simplified device, but can't I use my smartphone instead? And at that moment, I realized that she was almost 80 years old. I didn't think, and due to my implicit biases, I grouped her with everyone in that age group. I didn't think she would want to use her iPhone 13, which is ill on my part because I didn't treat her and individualize her as a patient and ask her, what is most convenient for you? Do you utilize a smartphone? Instead, I educated her and I counseled her on a whole separate device that she would have to carry around in her purse when she's utilizing her iPhone and her smartphone all of the time. So really making sure that I evaluate patients based on who they are personally rather than affiliations with other groups, leading into those implicit biases more and more. Moving on to C is check your messaging. Embrace evidence-based statements that reduce implicit bias, such as welcoming and embracing multiculturalism. You and only you are responsible for your own education, so making sure we're getting information from reputable resources. I, institutionalize fairness. Promote procedural change at the organizational level that moves towards a socially accountable healthcare system with the goal of health equity. And we'll talk about this a little bit more when we talk about institutional level recommendations. And finally is take two. Practice cultural humility, a lifelong process of critical self-reflection and readdress the power imbalances of the clinician-patient relationship. So take individual responsibility to deepen your own awareness. You and only you are responsible for your own growth and own development. When it comes to completing these actions for ourselves to enhance our interpersonal connections with patients, remember that we took an oath as pharmacists that commit us to these actions. And very timely, the new oath was revised. So the new revision started in 2021 and is now adopted, specifically addressing these DEIA issues. So I have the new updated highlights here on your screen in red. So I will apply my knowledge, experience, and skills to advance health equity to ensure optimal outcomes for all my patients. The fourth bullet down states, I will accept the responsibility to improve my professional knowledge, expertise, and self-awareness. And then a new statement altogether is, I will champion diversity, equity, inclusion, and anti-racism. But don't forget, even if we are committed to these things, that our implicit biases can run contrary to our conscious thoughts and our conscious actions. So it's really important that we do that self-introspection and that self-reflection on what those implicit biases could be. All right, now coming back to this interpersonal level, we talked about actions for ourselves. What about actions for others? Actions we can engage with others. So first I have medication counseling and education to parents, caregivers, family, and social circles. So help increase awareness and education, competency of family members, invite them in to engage with the care of the patient, make them part of the team to strengthen that relationship. And then the second one is more specifically for faculty members. So develop the requirement for education or training to include anti-racism and implicit bias education in the pharmacy curriculum. So specifically for our faculty members, helping to improve the education of our future pharmacists, or even so our preceptors that are out there for our future pharmacists. We are already previously discussed and talked about how important it is and the way in which we teach and approach this information. So this is definitely something that we can employ as well. All right, moving right along in our social ecological model. Let's look at actions and interventions pharmacists can make at the institutional or the practice or organizational level. So this is education, training, skills enhancements of institution members beyond the target population and immediate context, including institutional leaders. So this is modifications to institutional environments, policies, or services. So some things that I have listed here include establish equity and recruitment and hiring processes, create sustained space to engage in dialogue around anti-racism and implicit bias with colleagues, establish equity and leadership to create opportunities for minority individuals and create processes for support. And then I have review and revise organizational policies and standard operating procedures to ensure that they are equitable. When were your current policies adopted? When was the last time that they were reviewed? It's really important to try to identify any policy gaps and opportunities to strengthen policies, procedures, and positions related to diversity and equity. And to continue on with some other actions I have listed here is mandatory implicit bias training for employees, creating specific task forces or committees to lead anti-racism efforts. So examples could be a director of diversity or a chief diversity officer position, or maybe you can create a task force or committee like a diversity, equity, inclusion, and anti-racism and accessibility task force, for example. And also improve the use of EHR for automatic screenings, for example, social determinants of health screenings to triage and identify at-risk individuals and interventions. So this is something that we currently have at my practice site where we do a social determinants of health screening for every new patient, and then we do an annual screening. And based on what that screening is, it then sends an automated triage message to, a community health worker that can help our individuals who are at risk, and we can triage and think of any interventions to identify these patients and give them the care that they need. Moving out even further, now let's talk about interventions pharmacists can make at the community level. So this is education, training, and skills enhancements of the general community, including community leaders. I broke this into two categories, so community engagement and community needs assessments and planning. So first, for community engagement, I have written develop relationships with local service organizations, and then I also have volunteering, so healthcare volunteering and non-healthcare related volunteering. Pharmacists can reach out to local community organizations and develop relationships with local social service organizations. So things such as food banks, transportation services, and they can establish their pharmacy practice as a community-based referral center. In terms of volunteering, this can happen in the professional setting. So examples would be health fairs or clinics. You can lead a seminar in a local school or give presentations to, residents of a long-term care facility. On the other hand, pharmacists may also participate in efforts unrelated to professional roles, but these things can also impact the neighborhood and impact the community. So such as community cleanups or building community gardens, for example, is something that we did in a neighboring city. But through purposeful community engagement, pharmacists reinforce their roles as trusted members of the community. And additionally, they gained valuable insight into the needs of the communities that they serve when they are involved. Moving on to the other side of this slide, we have community needs assessments and planning. So first, I have advocacy to community leaders. Through actively listening to community members, pharmacists can be made aware of issues of larger concern. So for example, if there's this recurrent barrier of transportation for our patients, pharmacists can raise this concern to community leaders to advocate for improvements in public health and for public transportation, grants for bus fares, grants for Ubers and Lyfts, and so on and so forth. And then also I have listed here community-based participatory research. So pharmacists as researchers can contribute to the body of established community knowledge. For example, patterns that we can detect from social needs screenings can be communicated to public health organizations to support the design and implementation of community-level interventions. Essentially, as we know, as pharmacists, we're uniquely positioned to understand the needs of our patients and our populations, and we can connect the needs of our communities to health out and their health outcomes to public health officials to hopefully come up with some tangible solutions. We're like a liaison in this unique position. And then finally, moving on, last but not least, is public policy and system-wide interventions that I have listed here. So public policy and system level interventions are enhancements to public policies and or perception/attitudes of policymakers. Examples include things such as political advocacy, campaigning, direct communication to policymakers, lobbying, engaging with state and national societies. As pharmacists and trusted leaders of the community, we can leverage our relationships that we have with local health departments and city and county leaderships to advocate for our patients and the community on a wider level. So for example, pharmacists can have supported environmental programs such as water pollution control, sanitation, and waste disposal. On a broader level, pharmacists can engage with state and national societies to support policy change. The current accessibility of pharmacy services today has been due to advocacy efforts just like this that we're mentioning. So immunizations that pharmacists can give, collaborative practice agreements, point of care testing, all of the things that we have and that we're involved in, these are relatively recent innovations and expansions of our practice that are backed by legislative transformation that has recently happened over the time due to this advocacy. And also, pharmacists may want to take things and their leadership to the next level through seeking elective positions in local, state, or national governmental legislative bodies. So overall, through individual and professional advocacy for identified population health needs, pharmacists can truly impact health equity at this macro level, at the public policy or systems level. So after discussing those potential actions for consideration, I want to end on this graphic that's titled Social Determinants and Social Needs Moving Beyond Midstream. So our stream that we see here is broken into 3 sections, and you may be familiar with this stream analogy. So we have the upstream, the midstream, and the downstream. Upstream, we have community or macro level impact, and then we move more downstream to more individual impact. Remember that vicious cycle that we examined before, and it was that really cool graphic that we saw from Dr. Creer Prairie, and it was regarding racism being a root cause and how that trickled down to the individual patient level, causing health disparities. Historically, healthcare providers have provided downstream interventions, so individual patient treatment for chronic diseases through medication management or emergency services for our marginalized patients. However, in order to substantially reduce health disparities from the beginning, an upstream approach that addresses a community's underlying social and economic conditions must be considered. So the upstream approach proposes a shift in addressing health disparities by identifying the root cause, aka systemic racism. And we see these effects as observed downstream. So while understanding the importance of downstream interventions, an upstreamist is a practitioner who is dedicated to the thorough assessment and the treatment of social determinants of health, and they can advocate for social justice. So think about it this way. If someone is polluting a river upstream, all of the pollution is going to trickle downstream. Efforts would be needed downstream to clean up the mess, and we can 100% intervene successfully downstream to clean up that mess. However, the pollution is still going to trickle down unless we do something to physically address that source of pollution that is happening upstream, aka at that macro level. The demand for social needs interventions won't stop until the true root causes are addressed. And this is an attempt to proactively address root causes instead of being more reactive, if that makes sense. And additionally, we're talking about upstream, but midstream strategies to mitigate immediate social needs or to identify social risk factors are a growing area in which healthcare providers, specifically pharmacists, are well positioned to step in as well. Remember, this is our goal when it comes to racial justice. We can 100% identify and address the inequality for each individual patient and customize the care we give them, aka equity that we talked about with our analogy with the 2 boys picking the apples. But remember, our overall goal is justice, and that is to engage in deliberate systems and supports to achieve and sustain racial equity through proactive and preventative measures. So finally, after that is all said and done, to conclude it all, let's revisit those pre-test questions. There is no official polling software during this presentation, but I will reveal the correct answers this time. So I encourage you to self-assess yourself, write them down, or just think through thoroughly before answering. So our first question coming back to it was, race is defined as which of the following? A, a social construct, B, a biological construct, C, genetic construct, or D, all of the above. And thinking it through, and after looking at the Pew research and the consensus and how our race categories changed based on political and economical and social needs of a society at that time, the answer here is A, social construct. Moving on to question number 2. The conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks is the definition of which of the following? Is this A, social determinants of health, B, systemic racism, C, racial equity, or D, cultural competence? The conditions in the environments where people are born, live, learn, work, play, worship, and age. So the answer to this one is A, social determinants of health. Moving on to question number 3. This one was a true or false. The upstream concept, which we just reviewed, proposes a shift in addressing health disparities by identifying the root causes of concerns geared towards targeted macro level interventions. So true or false, the upstream concept is identifying root causes geared towards macro level interventions. And yep, you guessed it, that answer is true, as opposed to a downstream concept individually addressing patients or the individual. And then finally, the last question here is more of a self-reflection. Now that we've gone through different strategies using the social ecological model from intrapersonal, interpersonal, the community level, the institutional level, what are some effective strategies you can implement as a pharmacist to best address health disparities? I understand all of us here on this call and listening to this webinar, we all have different roles. We all have different professions in the world of pharmacy. So what can you do specifically in your role, in your job title, that can address health disparities? So that concludes all of the information I have for you today. I will leave you with our animal image from the beginning, hoping that after getting involved in this discussion, your lens and your perspectives are broadened to consider additional things you may have not have thought of before, or even to expand on some concepts and ideas that you have already had much thought about. But regardless, hopefully you're able to appreciate a broadened perspective, considering the effects of systemic racism on health outcomes and where you, as a pharmacist, can play a vital role. So with that being said, I will open it up to any questions that we have with our remaining minutes here. And then also as well, if, taking in this information, I know it can be a lot. If we do have questions or something you want to chat offline, here is my email address that I can, we can definitely have some more personalized conversations. I'm eager to, gain insight from others and discuss and talk about these things as needed.
So just one last call if anybody has any questions for Dr. Lewis before we move on. So it looks like someone in the chat has a question. So the question is, so should we stop saying certain races have more of a disease?
No, I don't think, I think epidemiology and looking at statistics, I don't think stopping to say that because it is fact, but I think, trying to understand the underlying problem or what could potentially be the root cause. And we won't always know those things, but especially in the example that I gave from, teaching my students is just talking about half of the story. Why is that happening? For example, next week I'm giving a presentation on maternal mortality and looking at the health disparities with maternal mortality. And those health disparities aren't because of a gene that's causing maternal mortality. It's due to social determinants of health and racial health disparities that we're seeing. So I think it's definitely, we definitely will still say that a specific race has more of a disease, but kind of making sure we're understanding the underlying cause and really addressing that root cause and having those discussions and not being afraid to have those discussions as well.
Okay, thank you for that answer. So if nobody else has any last minute questions, I will provide everyone with the CE code before we move into our next presentation. So the CE code for pharmacists is social. So it's SOCIAL, and the CE code for technicians is outcome. And it's written in the chat as well, if anyone didn't hear. So thank you very much, Dr. Lewis, for today's presentation. It was very informative.
Thank you guys so much for having me. And then these are just my resources or my references here, my citations, and I know the slides will be shared. Thank you guys so much for your participation, your open minds, and for being here on a Friday Eve. And I hope you guys have a great rest of your day listening to the other presentations.
Thank you.
All right. Let me just share my screen. All right, hopefully you can all see that. Okay, well, my name is Katie Cardone, and I am faculty at the Albany College of Pharmacy and Health Sciences, as Shanice said in the introduction. I've been working in nephrology. I think the first time I set foot in dialysis was almost 20 years ago. And so I've been in the outpatient nephrology space for quite a while, and things have obviously transformed and changed over that time, with regard to estimating GFR, assessing kidney function. Today, I'm going to touch on health disparities, and we're going to talk about the new estimation equation that was published last year. And I'll talk a little bit about that evolution for that equation to be created. I'm going to just turn off my video, but I will turn it on at the end to help with bandwidth. All right, my disclosures are on the slide. I have served as a consultant for GSK. My spouse works for Fresenius, which is a dialysis company, and I am a named investigator on a Merck RCT. The objectives, so today we're going to cover a little bit about health and healthcare disparities in the United States relevant to chronic kidney disease. We will distinguish between social and physiological determinants of health. We'll talk about the rationale for removing race from the eGFR calculation. We'll use the CKD-EPI equation to evaluate pharmacotherapy among people with CKD and identify steps to close care gaps among people with CKD. First and foremost, it's important to recognize that chronic kidney disease is a public health concern. CKD is associated with significant mortality risk and a plethora of morbidities, significantly so that we have an increased risk of cardiovascular events. And of course, as CKD progresses toward kidney failure, there is a need for some patients to get a kidney transplant or to start dialysis. When we look at the estimates of how many people are actually affected by chronic kidney disease, the most recent number is about 1 in 7, and that's approximately 15% of American adults with chronic kidney disease, which is a big number, and that's an increase since numbers we've seen, a decade ago, which was, 1 in 10, for example. The Healthy People Initiative is a public health initiative from our government, and chronic kidney disease is listed as one of the goals, specifically to reduce the burden of chronic kidney disease and related complications in the most recent update of the Healthy People Initiative, which is Healthy People 2030, but it has also been on the Healthy People list of goals for decades. Right now, there are 14 specific objectives that are related to chronic kidney disease, and I encourage you to go to that website if you're interested to find out how we're doing. We take a closer look, and these data are from CDC. We take a closer look at who has chronic kidney disease or where it's most prevalent. We see, of course, that as people age, CKD prevalence increases. Women have a little bit higher percentage than men. And when we look at this in subgroups from non-Hispanic whites, we see that the percentage of people who have that is about 12.7. And that equates to about 1 in 8 white people who have chronic kidney disease. If you look at non-Hispanic Blacks, that percentage is 16.3, and that's actually about 1 in 6 people who identify as Black who would have chronic kidney disease. So what is chronic kidney disease? What is the definition? How is it diagnosed? CKD is defined as abnormalities of kidney structure or function. It has to be present chronically, and we define that as at least 3 months, and it has to have implications for health. We can further define CKD based on its underlying cause, based on the GFR category, and also based on the amount of albuminuria present. These are the staging categories for chronic kidney disease. And so for a patient who has a GFR under 60 for at least 3 months, that person automatically has chronic kidney disease. And the stage is defined by how far below 60 that person's GFR is. For a person to have a diagnosis of category G1 or G2, and again, those people have either normal GFR or a mildly decreased GFR, there needs to be damage present, and usually that manifests as protein in the urine or albuminuria, but it can manifest in other ways as well. The albuminuria categories are listed here on your slide. Not the focus of our talk today, but nonetheless, for completeness sake, for people who have normal amounts of protein in the urine or very little protein in the urine, they're categorized as A1, moderately increased amounts A2, and severely increased amounts of protein in the urine would have category A3. And so we would put all of that information together and think about the prognosis for our patient, the risk of adverse outcomes. And so for a patient who has, very low GFR and, significant amounts of protein in the urine, those people are at very high risk for poor prognosis. But even people with normal or relatively normal GFR, if there's a lot of protein in the urine, those people are at high risk for a poor prognosis. And so it's important to make sure that we're getting each of these categories correct, that we're able to figure out, at what G category is the patient and how much protein is in the urine. And as pharmacists, of course, once the person has been staged, we can start to think about a medication regimen that makes sense for that patient to decrease the risk of progression of kidney disease and also for cardiovascular events. So how do we determine GFR? There's a number of ways that we can assess kidney function, and of course, creatinine-based methods are the most popular. Over the past 50 years, there's certainly been a change in the way that we assess kidney function. Serum creatinine alone is not usually a good marker of kidney function. We can look at changes in serum creatinine, but we certainly have more sophisticated methods nowadays to assess someone's kidney function. We can measure creatinine clearance, and that is usually done with a 24-hour urine collection, and I have the equation here on the screen, but essentially this is not routinely done, and there are limitations to asking a patient to do a 24-hour urine collection, and so this has largely fallen out of favor. Occasionally, our nephrologist office will order a 24-hour urine collection, but that is done, in selected patients and certainly not across the board. We do have estimation equations, and this is probably what we're all very used to using in our institutions. And our individual institutions may have specific equations that they use, or a protocol, or instructions on how to use some of these equations. Cockcroft-Gault, I think we're pretty familiar with, estimating creatinine clearance with the Cockcroft-Gault equation. And then we have the MDRD and CKD-EPI that have been used to estimate GFR. I'll start with the Cockcroft-Gault equation, although it's, again, not really the highlight of today's talk, but this equation was initially published in the 1970s, and the equation is here. There's been a number of iterations of this and modifications of this over the years using different weights and different strategies to improve the accuracy of this formula. This is the original abstract, and I want to point out that there's a very limited group of patients who were involved in this study. So although we pretty much ubiquitously use this formula, everyone has to memorize the Cockcroft-Gault equation when they're in school, and we have to practice using it. We use it to dose medications. This equation was actually developed in only 249 white men. They were all in Canada, and there were no women, nobody other than white patients, and so very, very limited when this was created. Nonetheless, it has helped us over the years in establishing a patient's kidney function and really getting a reasonable idea of where someone is on the spectrum of kidney disease. So I've created two case examples, patient A and patient B, that we're going to follow throughout today's talk. patient A is a 63-year-old man. He's 5'10" and 70 kilos, and his serum creatinine is 3.3. And patient B is a 46-year-old woman, 5'3", 62 kilos, and serum creatinine is 1.2. I wanted to show you what some of these calculations would look like and why some of the changes with the different formulas matter. So here, and I know some of you are saying I should have used the ideal body weight equation. I actually, in our practice, we use the total body weight. So that's what I did here. But just as an example, you see that this person's creatinine clearance using the Cockcroft-Gault equation is about 23 mils per minute. For patient B, again, a 46-year-old woman, her creatinine clearance comes out to be about 57 mils per minute. Moving on to the MDRD study. So the MDRD study came out a little bit more than 20 years after the Cockcroft-Gault equation was published. And this was a much larger study, included 1,600 patients. It was a cross-sectional study and really was looking at glomerular filtration rate, creatinine clearance, serum creatinine, and a bunch of demographics in patients who had chronic kidney disease. And that's a really important aspect here, that every patient in the study had chronic kidney disease, which means all of the patients had a GFR under 60. And so that's an important consideration when we think about who we can apply this formula to. What the investigators did, they actually measured GFR. And so this is different than measuring creatinine clearance. So when we're measuring creatinine clearance, we're doing a 24-hour urine collection, but creatinine is an endogenous compound, and so we don't need to actually inject anything into our patient. However, if we want to measure GFR, we have to administer intravenous iothalamate to the patient, and it's pretty laborious. And so it is not done routinely in clinical practice, and that is why we are, spending all this time learning about estimation equations. All right, so the investigators then collected all of this data and used regression modeling to identify factors that affected the glomerular filtration rate, and they developed a prediction equation. This is the equation that was published in 1999, and one of the statements in the article, quote, "At any given GFR, the serum creatinine concentration is significantly higher in men than in women, and in Black persons than in white persons." And so there is an adjustment for race in this equation. And so you see that there's an 18% adjustment for people who identified as Black on their demographic forms. All right, so if we plug in the results here for our patient A, we see that the GFR using the MDRD is 23 if the person was identifying as Black, and 19 if the person was identifying as non-Black. And so that is crossing a threshold, which we'll talk a little bit about in a few minutes. But essentially, when you have patients who, if you identify as Black versus non-Black, and there is a significant clinical consequence of being above or below a particular cut point, in this case 20, that can affect our clinical practice and clinical care. And then for patient B, again, her GFR is a little bit better. So her eGFR, if she identified as Black, was 59, and eGFR for non-Black was 48. All right, so importantly, both the MDRD and the CKD-EPI equation, which I'm going to mention in just a moment, include a race coefficient. And this was seen in several data sets. So the NHANES data and the MDRD study data showed that there was a higher serum creatinine concentration in Black study participants compared to white participants with the same measured GFR. And so at the time when the MDRD equation was created and when the CKD-EPI equation was created, this was seen as an advancement because there was essentially adjusting for factors and identifying differences in different patient groups. And so that is why these adjustments essentially were added to these equations. The CKD-EPI equation was designed similarly to the MDRD equation. Again, it was a cross-sectional study, and there was a sample, there were data from 10 studies where there was measured GFR, again, that IV iothalamate was used. And then there was a validation sample that included almost 4,000 patients. So even bigger study at this point. And the CKD-EPI equation also included patients with normal GFR. So not everybody had just CKD, it was people at all ranges of GFRs. Now, when you look at this equation versus the MDRD, it actually improves accuracy by about 4%, and it is definitely more accurate at the normal GFRs because, again, it includes those patients in the data set. This is the equation, and after this was published, the KDIGO 2012 CKD guideline recommended that the CKD-EPI equation be used by laboratories when they're reporting eGFR, unless something better came out. Nonetheless, we know that most labs still are reporting out MDRD results rather than switching over to the CKD-EPI equation. If we look at our case example here, the CKD-EPI comes out, our patient A, the eGFR is either 22 or 19, depending on how the patient identified, either Black or non-Black. And then in patient B, we're looking at GFRs of 63 or 54. And again, here is another example in this patient where we see a cut point. We're crossing that 60 threshold, depending on how the patient identifies. And that does have, again, implications for care, whether the person has a GFR under that 60 or over 60. All right. In 2012, there was another study published, the CKD-EPI cystatin C study. Cystatin C is an endogenous filtration marker. It is not affected by muscle mass or diet. And so when this became available, it was seen as a potential improvement over serum creatinine because, as you know, when we have very small, frail individuals, very large individuals, or people with vegan diets, this can affect potentially our GFR estimation, anything that's using creatinine in the equation. And so cystatin C seemed like a really promising marker of endogenous filtration. So it is available in some labs, but even 10 years later, it's not widely available. Not everyone has access to cystatin C at their hospitals or labs, and it isn't widely used in practice. But if we look at the different equations that were created and published over 10 years ago now, the CKD-EPI equation that used cystatin C instead of creatinine has similar accuracy to the CKD-EPI equation with serum creatinine, and it contains no race coefficient. The CKD-EPI equation that has both creatinine and cystatin C in it is actually more accurate than either of those equations alone, and it does contain a race coefficient. If we look at the results here for our patient B, we have the CKD-EPI creatinine equation from 2009, and I already showed you those results. If we look at the cystatin C, without the creatinine in the equation, those results are present. And again, they're equivalent because there's no race coefficient in that equation. And then if we use the equation that includes both creatinine and cystatin C, you see the results there. So either 60 or 56. So in summary, we have the MDRD study equation that was established in people with chronic kidney disease, and it does include that race coefficient. We have the CKD-EPI equation that includes people across a range of GFRs, but it does also include the race coefficient. And when you look at these equations now, you can really identify that there is a biological rationale for including age, sex, and weight potentially in these different equations, but it was unclear why race affected eGFR estimation, and it still is. As Dr. Lewis mentioned in her presentation, race is a social category. It captures diverse ancestral backgrounds, social determinants of health, and other factors. And so, with all of that history and all of those things that are compacted into that one category, it's unclear what is actually affecting the results here. Why are we seeing a higher serum creatinine at the same measured GFR for people who identify one way versus another? Let's take a look at some of the disparities and care gaps that exist. So care gaps are identified as a discrepancy between a best practice and an actual treatment, and disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. All right, so these disparities that I'm going to share with you kind of span all the way from risk factors for chronic kidney disease to treatment of kidney disease and then establishment of kidney disease. And so the first thing here, and these data are from CDC on this slide. So the prevalence of hypertension is higher in non-Hispanic Black adults than in non-Hispanic white, Hispanic, or Asian adults. And you can see the prevalence listed here on the slide, significantly higher in people who identify as non-Hispanic Black. All right. American Indians, Alaskan Natives, non-Hispanic Blacks, and Hispanics have higher rates of diabetes than Asian Americans or non-Hispanic whites. So those are both risk factors for chronic kidney disease. Now, if we look at, care gaps within people who have diabetic kidney disease or who have diabetes and we're screening for kidney disease, that's listed here on this slide. And so this doesn't necessarily point to a disparity, but points to significant care gaps. And so along the first column all the way to the left, you see the evidence-based recommendation for this patient group. And then in the middle, you see the implementation rate that's been published in different studies. And then the implication for those low implementation rates in the rightmost column. So the recommendation to test for albuminuria. This has been implemented between 10 and 40%, depending on the study that's published. And if we're not testing for albuminuria, we have obviously decreased diagnosis, prescribing, and monitoring for those patients. The recommendation to use RAS blockade has been implemented between 25 and 40% on average. And of course, not using these agents in people who could benefit could lead to CKD progression, kidney failure, or cardiovascular risk. Recommendation to use SGLT2 inhibitors is at 13%, and this number is moving, I think, because there's more and more evidence here. And of course, that leads to more CKD progression, kidney failure, cardiovascular risk, and mortality. And then from a GLP-1 receptor agonist perspective, implemented 17% of the time with implications for cardiovascular events. There's also emerging data, and most of it at this point, to my knowledge, is secondary data, secondary outcome data, that GLP-1 receptor agonists also confer some kidney protection. All right, so thinking about screening again, in a study where 44% of non-Hispanic Black participants had a clinical risk factor for chronic kidney disease, only a quarter of them reported being screened for CKD within the last year. And then for people, using SGLT2 inhibitors, there are disparities within use of those agents. So for SGLT2 inhibitors, we are seeing that the use of these again is increasing. In the period that looked from 2015 to 2019, we saw that more and more patients were getting these medications. However, there were inequities identified, and they were on the basis of Black race, being female, or having a lower socioeconomic status. All right, and what about having overt kidney failure from diabetes? So if we look at this from 1996 to 2013, you can see how different groups of patients have been affected. So along the y-axis, you see the percent of people who have kidney failure from diabetes. Along the bottom, you see the different groups of patients. In the navy is from 1996, and in the gray is 2013. And so there's been significant improvement among Native Americans, but the other groups have not changed substantially. You can see that there's much higher prevalence among Black patients versus Asians, whites, and there is quite a high risk also with Hispanic patients. And then Dr. Lewis did mention a lot of social determinants of health, but this is another slide kind of pointing at the fact that location matters. Many of our health outcomes can be predicted by county. So, your zip code can determine, where you're likely to be from a health perspective down the line. People living in areas with lower life expectancy are less likely to receive information about kidney transplant, see a nephrologist, or have the proper dialysis access placement, so AV fistula placement for vascular access. Proximity to a pharmacy, of course, affects medication access, and distance to a grocery store affects likelihood of developing kidney failure in people with chronic kidney disease. And so it's thought that some of these factors, the social determinants of health, might be some of the reasons why we see the higher serum creatinine among certain groups of patients, even at the same GFR. And that doesn't necessarily explain the whole picture. There are a lot of things, as we said, that are captured within race. And so social determinants of health are one of those things. There's a lot of diversity among different racial groups, and that needs to be recognized as well. With all of that being said, there was a desire to actually take a closer look at our equations and some of the assumptions that we make with having the inclusion of race in our kidney assessment formulas. So in July of 2020, the National Kidney Foundation and the American Society of Nephrology established a task force with a charge to reassess the inclusion of race in the estimation of GFR in the United States and its implications for diagnosis and subsequent management of patients with or at risk for kidney disease. Importantly, it was comprised of a diverse group of healthcare professionals, patients, and others. And there absolutely was pharmacist representation in this group. Wendy St. Peter out of University of Minnesota served in that role. The committee took a phased approach. Phase 1 consisted of clarifying the problem and examining the evidence. Phase 2 was evaluating possible approaches to deal with this issue. And phase 3 were to make recommendations. So let's take a closer look at phase 1. Phase 1 is when, of course, they were clarifying the issue. And what the committee did was they evaluated the literature, they held expert panels, lectures, they brought people in for testimony, and they held specific sessions on the history of GFR evaluation over the previous 50 years, GFR measurement in the United States, race and racism, genetic ancestry and race, creatinine, race, and ancestry, body composition and eGFR, laboratory standardization and issues, patient perspective and decision-making, and possible approaches to address race in GFR estimation. During this time, there were a lot of deliberations and different perspectives were heard. And I very much encourage you to pull some of these publications if you're interested in hearing more or reading more about the process that was undertaken. I've tried to excerpt each of the 3 phases of their approach here in this presentation, but there's definitely a lot more detail that provided in some of the tables and figures in the documents that were published. And so just to give some very, very, very high level comments about the pro and con debate about removing race from the GFR equation. There were a lot of people, a lot of proponents that said race should be removed from the eGFR equations. And that's because race is a non-biological social construct. The benefits of removing race from the equation would lead to earlier identification of CKD, for Black patients and referral to nephrology and transplantation earlier for Black patients. And on the negative side, there were others who said we should not remove race from the equations. There are identified differences between the groups, regardless of the reasons, and that needs to be captured. And so these people said that, removing race might lead to other disparities. And so this was weighed heavily among the task force members. And what the task force ended up doing was establishing 30 evidence and value statements. And I have 3 examples I'm going to share with you, just so you can see how these were structured and what they sound like. But there are many, many more details, again, listed in the publications. So equity in health and kidney health care is a fundamental and important goal, and that's a value statement. Race is defined as a construct of human variability based on perceived differences in biology, physical appearance, and behavior. Race and ethnicity are social and not biological constructs, and those are evidence statements. And then finally, multiple studies among the US population, including national health statistics studies across age groups, show African American men and women have higher serum creatinine concentrations than their white counterparts. Not all factors that might affect serum creatinine concentrations were accounted for in these studies. Studies have also shown African Americans have higher serum creatinine concentrations than white individuals at the same measured GFR in the United States. And importantly, the reasons for these differences are not understood, and these are evidence statements. From there, the task force looked at possible approaches to estimate and report GFR, and they identified 26 different ways that they could possibly address the issue. There were 12 strategies that used creatinine as the biomarker. There were 13 that used a non-creatinine biomarker, and 1 used a combination of methods. From there, we have phase 2, where the committee evaluated possible approaches. And so at this point, the task force, after reviewing all of the testimony and information from phase 1, agreed that race should be removed from the eGFR estimation equation. From there, they were looking at the different approaches that removed race from the estimation equation, and they rated them based on 6 attributes. So they looked at filtration marker assay, implementation challenges, equation population diversity, equation performance, consequences, and patient-centeredness. So looking at the filtration marker assay, creatinine is standardized and available, and it's high throughput for labs. Cystatin C was not as widely available and more expensive. And so it was felt that most likely we would need to use a creatinine-based method to move forward with. Looking at implementation challenges, some of the strategies that were proposed included using height and weight that would need to be included in the equation, and that could pose challenges for labs when that information was not reported. There was also a pitch to use regional equations to reflect the local diversity within a specific community, and that was felt that would be very challenging to do and would lead to other issues. And the Cockcroft-Gault equation was also proposed, but it is not validated with a standardized creatinine assay. Looking at the equation population diversity, ideally the study sample would reflect the United States population, and this is across the different considerations. So racial and ethnic group representation would need to reflect the United States population. We would need to have a diversity of age and also sex. The equation performance was also looked at, accuracy, bias, and precision specifically. So accuracy, an equation was deemed accurate if there were many estimates that were within 30% of the measured GFR. Bias is the median difference between measured and estimated GFR, and precision is essentially the variance between the different measures. The task force spent a lot of time looking at clinical consequences and research implications, and there is a lot of discussion on this area. And I definitely think it's worth taking a look at, again, this second publication by Delgado and colleagues, if you're interested in reading more about this issue. And I'll talk about some of them, but I certainly will not get to all of the consequences. And then finally, patient-centeredness. Patients desired earlier CKD detection. They really wanted transparency and communication with healthcare providers. And importantly, they really highlighted the fact that whatever they came out with, they wanted to make sure that it had the potential for shared decision-making. From there, the task force narrowed the list of approaches to 5 candidate processes. The first one was the CKD epi equation using the non-Black estimate. And so you saw the CKD epi equation that I showed you earlier. Essentially, this proposed using the non-Black estimate for all patients, whether they're Black or non-Black. The second proposal was to use the CKD epi equation using creatinine and refitting the equation without the race variable. The third was to use a combination of creatinine and cystatin C and use the non-Black estimate for all patients. The fourth was to use the combination of creatinine and cystatin C refit without the race variable. And finally was to use the CKD epi cystatin C equation. All right, so at this point, we know that we're going to be removing the race coefficient from the equation. I'm asking you as the audience to consider what effects removing the race from the equation might have on medication use compared with using race-based equations. And then, as you're kind of considering that or contemplating that in your head, are the effects different for Black versus non-Black patients? I'm going to walk through some of the potential effects, but certainly can't cover all of the effects. There are a number of clinical consequences that the papers review with moving forward with any one of these 5 equations. But I thought, since this is a pharmacist focused presentation, let's look at the medication implications first. So for Black patients, the newer equations may underestimate eGFR for some patients. We might see from there, if we have that underestimation of eGFR, that we see inappropriate underdosing or discontinuation of some medications. And we would likely see more diagnosis of chronic kidney disease, which would lead to us using more medications that could slow CKD progression. So more use of RAS blockers, more SGLT2 inhibitors, and more MRAs. However, a more serious CKD diagnosis might prevent the use of SGLT2 inhibitors at the lower GFR threshold. So if you had a patient who had a GFR in the upper teens, you might not be able to initiate that medication. And then for non-Black patients, if we're using the CKD epi for non-Blacks, there would be no change if we switched equations. If we use the refit equation with creatinine in there, we may overestimate eGFR for some patients and leading to less CKD diagnoses for that group of people. And this could lead to inappropriate overdosing or continuation of medications that should otherwise be discontinued. Another thing mentioned in the paper is that medication clearance is best evaluated using non-indexed eGFR compared with indexed GFR. And so there are limitations on using indexed eGFR for medication dosing. And what I mean by that is, if you're indexing, you're using units of mils per minute per 1.73 meters squared. And if you're non-indexing, you're actually looking at the patient's actual body surface area to express the eGFR in units of mils per minute. And so if you have a patient who has a significantly different body surface area from 1.73 meters squared, you're at risk for under or overdosing that patient, depending on which direction that person is. So if their body surface area is significantly less than 1.73, then you might be at risk of overdosing the patient if you don't index the GFR, and vice versa for larger patients. And this is an issue for any patient, regardless of race, but certainly within the American population, we see that there's more obesity, among patients, and we really need to consider this when we're medication dosing. Out of curiosity, if you were to type in the chat, does anybody's lab report the non-indexed eGFR on their lab reports? Our lab does not, but I know that some do. Okay. All right, so thinking about the clinical consequences again of, changing the equation. If we think about when we make decisions or when we make referrals to different providers or when we change practice, change care, we're doing it at different GFR thresholds. And I've alluded to this a little bit so far. If you look at the GFR spectrum, I just kind of stuck in here some of the thresholds that we might use. So 60, GFR of 30, GFR of 20, GFR of 15. First, all the way on the left, you see the kidney donor eligibility. And so this is an important characteristic. People have to have a GFR over 60 when we're assessing those patients. So if we start changing the equation where some patients are now going to have a worsened GFR number on calculation and some will have better, we have to think about what effect that would have on our donor eligibility. We'd have to think about CKD detection as our GFR declines, and are we kind of spilling over that threshold of 60 or not? Patients get referred to a nephrologist around a GFR of 30, so we need to think about that if we're changing where their threshold is. Importantly, we have transplant referral in there as well at a GFR of 20, and then vascular access referral around a GFR of upper teens, and then kidney replacement therapy when the GFR is under 15. And so kind of think about, as we move the numbers around, even just slightly, we could actually change some of these numbers, the prevalence of chronic kidney disease, the number of patients who get referred to different specialties, and different treatments that patients might receive. All right, so moving on to phase 3, what recommendations did the committee come out with? So number one, the committee identified that the CKD epi refit using creatinine should be implemented immediately. But we know that when we include cystatin C in the equation as well, it becomes more accurate. So national efforts should be made to increase the use of cystatin C. And that should be used to confirm eGFR or used in combination with serum creatinine to improve the accuracy of the outcome. Now, the reason that the committee ultimately did not recommend the combination equation, even though it was more accurate, is it's not as accessible. And so that's why the creatinine-based equation is the one that is recommended at this time. Further research is definitely needed on new markers that we can use to assess kidney function and ways to eliminate race and ethnic disparities. The committee also stated that eGFR should be indexed in its reporting. So the reporting should say mils per minute per 1.73 meters squared, with a notation that says use of non-indexed GFR and mils per minute should be considered for drug dosing decisions. And like I said, I do know that some labs report both of these. All right, moving on to implementation. So in the chat, does your institution's lab report eGFR using the new equation? All right, so definitely worth taking a look at to see what your lab is actually reporting. So that will be your homework after today, to actually take a look and see. I know on our lab reports, there's a notation that they will be switching, that they recognized. It was pretty quick after the recommendations were published that we saw that they were working on making the change. All right. So let's take a look at what this equation looks like. So the CKD-EPI 2021, which is the study that was published in 2021, removing race from the equation, essentially looked at 7 different equations before determining which one we should move forward with. So in recognition that race is a social and not a biological construct, the CKD-EPI data were reanalyzed to develop the new equation, removing the race coefficient. And they looked at 7 different equations. They looked at the existing or previous equations, the CKD-EPI that used creatinine, the one that used cystatin C, and the combo equation. And then they looked at removing the race coefficient from the EGFR creatinine equation and also from the combo equation, and just reporting the non-Black calculation for all patients. And then they also looked at a refit model. So they reanalyzed all of their data to look at the EGFR using creatinine and then also the combination of creatinine and cystatin C. All right, so if we were to report the non-Black calculation for everyone, there would be no change for non-Black patients when we made that, when we switched over to this updated way to report. But there would be a potential underestimation of GFR for some Black patients. They looked at the refit models and identified that there would be a potential overestimation of GFR for some non-Black patients and a potential underestimation of eGFR for some Black patients. And then they looked at the fact that the combination equation, again, was more accurate and minimized inaccuracies for both groups of patients. And then identified at the end of the day that the refit equation that uses creatinine is more equitable than the non-Black equation because there were some changes that would happen for both groups and those differences were averaged among all people. All right, so let's look at what this means. So for patient A, we have at the bottom here, you can see the new CKD-EPI equation, and this is just the creatinine version, not the combo version. But the GFR here shows us 20 for patients in either group. Let's take a look at what some of the consequences might be. So imagine patient A had type 2 diabetes. If we think about metformin dosing, we would have reduced the dose by 50% when his GFR hit 45, and we would have discontinued the medication when the eGFR hit 30. And so if you think about within that patient, kind of going back to his GFRs, you can see that depending on where he was, let's say we saw him a couple of years ago before his GFR was in the 20s, you could see that switching over, let's say our health system had the MDRD and then we switched over to CKD-EPI, his GFR would have dropped in one day. And our estimation and maybe his whole entire medication regimen would have been changed in one day because of that change with equations. So I think it's really important to see what equation you're using. And if you have switched equations, when did that switch happen so that you can make an assessment of what would have happened to your patient's GFRs over time. And then similarly, think about the threshold for initiating SGLT2 inhibitors in a patient like this. And so we'd want to initiate this medication when his GFR is still 20 or higher. And so again, if his GFR is going to just drop one day, his GFR might not have actually dropped for real, but the equation changed. And so that made a different assessment from a clinical perspective. Looking at patient B, here I have also included her CKD-EPI, creatinine, cystatin C equation numbers here as well. So you see that if we were just to use the creatinine, her GFR would be 57. And if we used the combo, her GFR would be 59. All right, so I think we pretty well talked about some of these different factors that we need to consider. But for our patient B, I think about this GFR cutoff of 60. And so I think it's important to note that she would potentially no longer be able to donate a kidney if her GFR spilled over into that under 60 category. All right, some other implementation considerations, time to implementation. So there are a lot of labs that are still using the MDRD, even though the KDIGO guidelines came out in 2012 saying that we should all be using the CKD epi equation at that time. And so we're a decade out and we're still not implemented. And so we want to make sure that that doesn't happen with the new equation. We want to make sure that everyone's using the same numbers. And so we really do need to get our health systems, our advocacy groups, and we need to make sure that we're all on the same page as far as what we should be using in practice. We need to think about practice change. How do we get our providers to start using cystatin C? How do we make it more affordable and more available? And then we need to train our healthcare team how to interpret the eGFR values over time. All right, so thinking about some of the implications, I don't work in a transplant clinic, but obviously my patients can benefit from kidney transplant. And the OPTN has some different initiatives and different policies that were put into place after the eGFR equation recommendations were put out. And so in 2012, the OPTN Board of Directors approved the proposal to establish the requirement for race neutral eGFR calculations. And then effective earlier this year, kidney programs had to assess their kidney waiting lists and correct the waiting times for any Black kidney candidates disadvantaged by having their kidney function be overestimated before the new non-race-based equation was available. And so different programs have evaluated this in different ways, but that was something that would have to be implemented at this point. All right, so what about the pharmacist's role in the last few minutes here? So we did publish pharmacy practice standards for working in kidney disease settings. And so there's a lot of standards that are really focused on direct patient care, as you would imagine. And we followed the pharmacist patient care process to come up with our recommendations for practice standards. If you look at the section of collecting and analyzing baseline information, kidney function evaluation is absolutely on there. This is something that every pharmacist working with patients who have kidney disease or who are at risk for kidney disease should be involved with. From an assessment perspective, obviously we're going to be looking and doing a medication review and identifying barriers to medication use, et cetera. But this is really where we need to think about the eGFR equation changes. Did our patient's kidney function actually change? Do we need to dose adjust a medication? Are we doing it properly? From a plan perspective, shared decision-making was one of the things the patient groups really said to the committee consistently. They want to be part of decision-making. And so I think it's important as these new numbers are available, we're talking to patients about them. And that was true even before we changed the equation, but this is a great time to talk with our patients since there are new data available. And then implementation and follow-up and kind of taking all of those things into consideration. From a population health perspective, and Dr. Lewis did talk a lot about some of these different things that we need to really do to care for our patients, but pharmacists need to participate in the development, revision, and implementation of protocols, especially now as we're potentially adopting a new eGFR equation. Everyone needs to be familiar if the equation changes because it will affect our assessment of our patients. We need to do medication use evaluations and make sure when we're around those threshold points, especially, we're paying close attention to what happened with our patients. And we need to promote equity to ensure all of our patients receive access to medication management. We should also be involved in public health and advocacy and teaching and dissemination of knowledge. So leading and participating in educational initiatives, health screenings, advocacy efforts, and providing education on kidney disease and medication management. So in summary, we have the updated CKD epi equation that is the preferred equation at this point to assess kidney function for people with chronic kidney disease. There are a lot of implications, including medication changes and needs. But a lot of those implications are still to be seen. If we're just in the process of implementation at this point, it might be a decade or so before we really know what the effect is. And pharmacists have a key role in promoting its use in practice. There are significant care gaps and disparities in CKD that exist. And so taking a look at this equation is a baby step in the grand scheme of things that need to be done to close these gaps and address these disparities. If you want more information, I put some links here, and you will have access to these slides, I believe, after the presentation. So there's the interim report that really details phase 1 of the task force, the final report that, of course, leads to the phase 2 and then the phase 3 recommendations. And then the refit equation is published at the publication listed there, but you can have access to that equation at kidney.org. Thank you all. I'd be happy to take any questions.
So thank you, Dr. Cardone, for providing that very informative presentation. So if nobody has any questions, I will provide you guys with the CE code. So for pharmacists, the CE code is determine, and that's going to be in the chat. And for technicians, the CE code is disease. And if you guys also need the CE codes for the first presentation, for Dr. Lewis's session, it was social for pharmacists and outcome for technicians. So in regards to the CE codes, you should all receive an email with within approximately 1 week with the links necessary to obtain the CE. And if you don't receive an email within 1 week, you may contact the NYSCHP office at ceprograms@nyschp.org. So thank you again to Dr. Lewis and Dr. Cardone. Both of these presentations were very informative and we appreciate it. And thank you all for attending the first half of our mini series. So we have the second half next week and we're excited to see everyone there.